Hi, everyone. My name is Carolyn Levita. I'm the Director of Respiratory Care Services at Massachusetts General Hospital in Boston, Massachusetts. Today, I'll be talking about volume-targeted ventilation in extremely low birth weight neonates. I do have some relationships with commercial entities that produce healthcare-related products and services. They are below in terms of advisory board members, consulting, and volunteering. The objectives for today will be to describe development of neonatal lung physiology, review existing literature for volume-targeted ventilation in the neonatal population, and define current barriers to use and strategies for management of this mode of ventilation in this population. It's helpful to start by discussing grading of bronchopulmonary dysplasia. This is a chronic condition of neonates, chronic lung condition, that is categorized based upon the respiratory support that the infant needs either at 36 weeks postmenstrual age or discharged to home. Patients are categorized as no BPD if they're on room air at this point. Grade 1 BPD is when they're on low flow nasal cannula with an FiO2 of around 30%. Grade 2 is when they require high flow nasal cannula, which is characterized by greater than 2 liters per minute. Grade 2 BPD can also include those patients who are on non-invasive respiratory support, and that can either be continuous or intermittent. And then grade 3 or severe BPD is when the patient requires a tracheostomy tube and an invasive positive pressure ventilation for significant periods at home. There are many different types of BPD grading, sometimes with different nomenclature. This is one that's commonly used in our neonatal ICU, which I think just gives a good picture of the spectrum of bronchopulmonary dysplasia. Fetal lung development occurs from the early weeks of gestation in the embryonic period all the way through birth and then actually after birth. We typically say that lungs are mature around 35 weeks gestation. That's been the historic cutoff in terms of enough lung parenchyma as well as enough type 2 alveolar cells which produce surfactant, and they at 35 weeks then produce mature surfactant. As lung development continues on again through birth and then after birth, we have this alveolar period where there is continuation of the alveolarization as well as vascularization of the lungs. The alveolar ducts continue to divide into alveolar sacs, and the pulmonary capillary bed expands to produce significant VQ matching and appropriate VQ matching. There's also airway remodeling that occurs later in gestation with increased dimensions of the trachea, changes to the geometry of the tracheal rings, as well as the chemical properties actually of the tracheal cartilage and smooth muscle that are throughout the airways. When we think about resuscitating children who are premature and more premature these days, at least in the United States, we've gotten down to a point where resuscitating children who are 22 weeks gestation. In my opinion, this picture allows us to just conceptualize what the lungs look like and what we're attempting to ventilate and provide enough gas exchange towards. 22 weeks, you can see there's some branching, but the terminal bronchioles are just forming, and the alveolar epithelium can actually still be on the thicker side. It has not yet thinned out to allow oxygen and CO2 to move across the alveolar capillary membrane. So it's much different. It's not just that the lung size is smaller in more premature infants, the actual development is significantly impaired. As we're resuscitating these children younger and younger and have smaller birth weight infants, we want to think about how to protect the lung as they're continuing to develop again through 40 weeks gestation and further beyond. And we need to take into account 3 different things. These are the triggers for ventilator-induced lung injury. Often children who are born premature do need to be intubated and or have some degree of positive pressure ventilation. And the 3 things to think about are barotrauma, volutrauma, and atolect trauma. Historically, as we've not had great volume measurements in newborns, tidal volume measurement in newborns, we've relied solely on barotrauma and have had a greater affinity to make sure that distending pressures are low, which is certainly good. However, even if distending pressures are low, if volume is much higher than physiologic, you can still have ventilator-induced lung injury. Atelect trauma comes from repeated opening and closing of the alveolar units, which is derived when the PEEP is insufficient. The alveolar units tend to collapse on expiration, and there's a great affinity, given the lack of surfactant and immature surfactant, for the lungs to collapse. So having PEEP, although we've historically been thinking that barotrauma and higher pressures is bad, having PEEP that's high enough to keep the lungs open is actually protective. So our shifting on that needs to think a little bit to make sure that lungs stay open and they don't collapse on exhalation. There are several challenges when ventilating a neonate, and they're all exacerbated when you think about ventilating an extremely low birth weight neonate. Sometimes we want to control for that tidal volume, and as we think about adult ventilation, we often think about volume control ventilation, but there is flow limitation. The flow and volume control ventilation is set and it's fixed during inspiration. So if the infant and or adult has varying flow demands, that it will not be met by the ventilator, and that will produce some patient ventilator asynchrony. In pressure limited ventilation, there's significant variable tidal volumes seen. This in neonates who have small tidal volumes to start with, if you have variable tidal volume for one reason or another, change in resistance or compliance, that can significantly alter your gas exchange, which can lead to desaturation and even bradycardia. Another challenge that we've seen in neonates is an accurate measurement of these very small tidal volumes. The technology just has not advanced until recently. We also have uncuffed endotracheal tubes and tracheostomy tubes, which require very sophisticated leak compensation from our ventilators. Determining optimal PEEP, as I was mentioning before, with atelect trauma can also be very challenging, especially with these smaller and uncuffed endotracheal tubes or tracheostomy tubes. These pressure volume curves are pretty well known when you think of pressure limited ventilation as compared to volume control ventilation, but I think really helpful to think about what's actually happening from a ventilator standpoint. In pressure limited ventilation, you see the pressure never changes. The inspiratory pressure or pressure control is limited by the ventilator. And so if you start on this blue pressure volume curve, and you have a decrease in either compliance or resistance, the pressure is going to stay the same, but the volume will decrease. If you start at the same point and have an increase in compliance or resistance, an increase in compliance or a decrease in resistance, your volume will go up. And so this pressure limitation produces variable tidal volumes, which again can have a significant impact on your gas exchange. If you turn it the other way around and control for the volume on this pressure volume loop, if the volume is going to stay the same, when you have a patient that has poor compliance, you're going to need a higher pressure to deliver that volume. If the compliance improves, the pressure required will be much less on this green loop here. So as neither of these are perfect by any sort of imagination for an extremely low birth weight neonate, and you can see that the variability in each has its own limitations. So if we take them and put them together into volume targeted ventilation, you kind of get the best of both worlds. You have a volume target that the ventilator, you program into the ventilator so the ventilator recognizes it, but the breaths are actually delivered in a pressure regulated method. The pressure is constant from breath to breath. The flow can actually be variable, improving patient ventilator synchrony. If the exhale tidal volume is lower than the target that you set, the ventilator will increase the pressure control to try to get to that target tidal volume. The converse is also true. If the exhale tidal volume is much higher, the pressure control limit will actually decrease to make sure that we're meeting both those barotrauma and volutrauma concerns. There's recently been significant interest in using volume-targeted ventilation in neonates, and there's been a few Cochrane reviews done. This was the latest that was done in 2017, and it compared volume-targeted ventilation to pressure-limited ventilation and looked as a primary outcome for reduction in death and/or death/BPD in newborns. The secondary outcomes that we're looking at were air leak, cranial ultrasound findings, and neurodevelopment scores. There are many databases that were used, and the authors looked at any randomized or quasi-randomized trials in infants who were less than 44 weeks post-menstrual age. What they found were actually 20 randomized controlled trials that produced about 1,065 infants. There were several parallel trials and then other crossover trials that they did also include because the methodology was very similar. None were blinded, but the quality of evidence related to the outcomes was moderate to low. If you compare this to perhaps the large randomized controlled trial of ARDSNet that looked at adult patients, in one randomized controlled trial, they had 861 patients. And so you can see in infants, it's much harder to enroll all of those enough infants to make the power high enough. And so in 20 randomized controlled trials, we got just a little bit more. So the quality of evidence is not as strong as perhaps we would like it, but the summary and the findings were impressive. So in all of these articles that were included, what was seen, and this is a table from the study, although it's very busy, and this is a synopsis on the side. Volume-targeted ventilation, when compared with pressure-limited ventilation, was associated with reduced rates of death or bronchopulmonary dysplasia, reduced rates of pneumothorax, reduced rates of hypocarbia, grade 3 or 4 IVH, and PVL with or without grade 3 or 4 IVH. It was also associated with decreased mean days of mechanical ventilation. Hypocarbia is actually incredibly important in newborns, and actually, in adults, we tend to think hypercarbia is bad as is associated with acidosis. Hypocarbia in infants, although acidosis is also poorly tolerated, hypocarbia can have a significant impact on cerebral blood flow, where it causes vasoconstriction. So the developmental status of the newborn with their premature neuro blood vessels also can have a profound impact from hypocarbia. So that really needs to be avoided. So from all of the summary, and this is probably one of the largest Cochrane reviews that we have looking at ventilation in extremely low, or in neonates, I'll say, it certainly favors volume-targeted ventilation. However, it's a fairly new mode for many people, and so there are considerations for successful clinical management that are helpful to know before you begin using it. The first is management of the target tidal volume. Where do you start? Dr. Martin Kessler is a large publisher and researcher on ventilation for neonates, and in 2019, this table came out in one of his papers that really targeted significant initial tidal volume depending upon the size of the baby as well as their presenting disease. Most often, the initial tidal volume is somewhere between 4 and 6 mLs per kilo, although certainly in established and severe BPD, it has been shown that larger tidal volumes can, overcome that alveolar and anatomic dead space that those patients exhibit. So somewhere in the 4 to 6 ml per kilogram range is a great place to start. And again, limiting the pressure along with it, coupled with it, is very important. In adult patients, which again is where most of the volume control ventilation has been proven to work, we use what's called the Devine equation that looks at the gender of the patient as well as the height. you can see if you plug in the height here and do the equation, you can get the ideal body weight for the patient, and then the tidal volume can be a derivative from that. That's only applicable if the height is greater than 60 inches, however, because it would make this portion of if it was less than 60, it would make this portion of the equation a negative number. So how do we look at ideal body weight for extremely low birth weight neonates? It's challenging because their weight can change very dramatically. If you think about a patient who's born at 500 grams, their 5 ml per kilogram target tidal volume is 2.5 mLs. If they then, as newborns typically do, gain weight over the first several days of life, and their weight now, their actual weight is 600 grams, if we keep the same 5 mLs per kilo, their target tidal volume is now 3. So it's very challenging to understand what weight we should be targeting, use as a base for our tidal volume setting. There is no data. There's no studies that look at what is the most appropriate method to do this. What's important to understand for the patient in front of you that you're treating is this growth, right? What we're trying to understand is the height changing where we have lung development and lung growth, or is the weight changing based on other parameters, perhaps fluid overload? Sometimes when they get a blood transfusion, their weight can actually go up. Are they starting to eat where their weight's, increasing more significantly in terms of an absolute body weight and not an ideal body weight, which is based on height? In our unit, we approach this as a multidisciplinary discussion. Once a week, we have a discussion about the individual baby and try to understand, are they growing? Do they have a lot of body edema in which, perhaps the actual weight that we're seeing is not reflective of height growth and lung development? We do plot their weight and height to just get a better picture to help us guide when we'll adjust tidal volume target and the tidal volume setting on the ventilator as the patient continues to grow. You also must understand your technical tools. I can't state this enough that the algorithms as well as the nomenclature from ventilator to ventilator are very different. You might have several ventilators at your institution in which you have to understand the algorithms of each. You might also be, conversing with colleagues at different institutions that use different ventilators. Something that's common in our NICU is accepting a transfer in of a sick neonate, and we have to make sure that we're understanding and talking the same language when we're discussing ventilator settings to make sure that the baby continues to be supported as they're transferred over. So the generic terminology is volume targeted pressure regulated mode of ventilation. Some ventilators call it VC+. This ventilator here calls it PRVC. Other ventilators in more of a spontaneous mode call it volume guarantee. As I mentioned, they do have different algorithms, and one that I have seen in our lab when we were evaluating ventilators was certainly the pressure adjustment in response to the exhaled tidal volume. If the ventilator recognizes that there's either a leak in the system or that the volume is decreasing, some ventilators, such as this one, which is what we use, that's the Neonates 550, that slowly ramps up, which, can be protective. If there's a positional leak in the tidal volume, then, comes back. Other ventilators might have a more radical increase in their pressure to overcome large leaks in the system, and so it's important to understand how your specific ventilator responds to these tidal volumes that may be either higher or lower than what your target set is. Leak compensation is also something that's incredibly important. I mentioned before, one of the challenges in ventilating neonates, and again, especially extremely low birth weight neonates, is the leak around their artificial airway, whether that's an endotracheal tube or a tracheostomy tube. Most ventilators either provide additional flow or pressure to maintain the PEEP and tidal volume that's set or delivered. Your ventilator, though, has to be smart enough to know as neonates are awake and moving, These leaks can be positional and can be very variable. So to have a ventilator that will recognize a leak, compensate for it, and then recognize when that leak goes away and perhaps uncompensate for it, take some of that pressure or flow away, is very important for in a specific consideration in neonates. Again, these are screenshots from our neon codon ventilators. You can see here that in the flow time waveform, there's a significant leak. The volume is not exhaled back to the ventilator, so it's not registered on the ventilator. Over the course of 5 breaths, the ventilator recognizes that the leak is present. And so there's a pause here as the ventilator readjusts. It adds flow to the circuit. You can see that the flow here is higher than the flows over here to maintain the tidal volume that's delivered to the patient and the PEEP that the patient receives. This ventilator can actually quantify the leak, which is really helpful. As I just walked through this, the tidal volume set is 6 mLs. This ventilator measures tidal volume at different points and can actually calculate what's actually delivered to the patient. So what leaves the ventilator is 6.1 mLs. What's delivered to the patient is 2.2 mLs. And so the leak percent is around 60%. As it then adjusts in the second picture here, the leak is still around 60%. What leaves the ventilator, though, again with this additional flow, is 16 mLs, and what's delivered to the patient is back to 6, which is exactly what we have set up. So the technology of the ventilator is responding in such that the patient is overcoming some of the technical issues and the patient is still getting what they need. You can imagine if the tidal volume is cut by 2/3, the patient is going to have hypercarbia and desaturation. The next consideration for management is utilization of the airway flow sensor. Some ventilators do require it. Some ventilators have technology where they can accurately measure tidal volume at the ventilator and don't need an airway flow sensor. My preference would be that to not use an airway flow sensor. The concerns that I have with it are as follows. It does provide some mechanical dead space. And depending upon the size of the airway adapter that you have, it's somewhere between 0.5 to 0.9 mLs between a neonatal and pediatric adapter. As in the previous example, if our tidal volume that's set is 6 mLs and we have up to 0.9 mLs of mechanical dead space, we need to compensate for that by increasing the respiratory rate to make sure that our CO2 clearance remains the same. There is physical weight of these flow sensors, which can lead to kinking or displacement of endotracheal tubes in neonates, especially when they're very, very small and pliable. Once they get in a heated isolate, they become very pliable. And so that physical weight can actually be very problematic. Humidification is important, and all ventilator circuits, especially in extremely low birth weight neonates, should be heated wire circuits. But the airway flow sensor is not heated, and so you have some degree of cooling, which then produces condensation as gas flow travels across the airway flow sensor. This again is right on the airway, and so any of that cooling and condensation of water vapor then can actually lead to aspiration into the patient's endotracheal tube, again causing significant tidal volume loss, desaturation, and bradycardia. These airway flow sensors are also typically not reusable, so they need to be reprocessed between patients. This adds significant operational challenges as well as financial challenges and infection control considerations for neonates. Often in patients that have had precipitous deliveries or complicated deliveries, newborns are born with a metabolic acidosis. Using a volume-targeted ventilation can be problematic with this acidosis. This was a study done now several decades ago, and it was in adult patients, but I think the operation of the ventilator is the same, and it can actually provide some good information. So half of the patients in this study were put on pressure support ventilation, the other half on volume support ventilation, which is the same principle as volume-targeted ventilation, just in a spontaneous mode. Both groups of patients had data recorded at baseline. And then they added, again, these are adult patients, mechanical dead space, which increases the CO2 clearance requirement for patients. You can see in the pressure support group, there is some level of increased effort. The flow increases as well as the patient becomes a little bit more tachypnic. There's changes in gastric pressure here, the diaphragmatic pressure here, but the airway pressure stays the same. And that's, pressure support ventilation. The airway pressure is set on every single breath. You get the same pressure. On volume support mode, the same things happen when we added the dead space. The patient had a higher effort. You can see this from increased flow and tachypnea. The frequency of breaths are coming, faster. The diaphragmatic contractions are higher. The gastric pressure is higher. And the esophageal pressure here is significantly lower, meaning the patient effort to get these breaths is much, much higher. And interestingly, what happens in the volume support group is the airway pressure decreases. So as the patient is more tachypnic and has increased work of breathing with this added dead space and CO2 clearance, the ventilator interprets that as the patient's doing better because our flow is higher, tidal volumes are perhaps higher. So it decreases the airway pressure. So you have to watch out for this for babies that have a metabolic acidosis. Again, the tip-off is typically a complicated or a precipitous delivery. It does take a day or two to clear, and it doesn't mean that in a state of metabolic acidosis you can't use volume targeted ventilation. You just have to be careful that the patient doesn't become too tachypnic and the ventilator does not under support the patient. This can be seen as the pressure control that's delivered to the patient, or the PIP that you see as the readout, will be very low, but the patient will be very tachypnic. So keep your eye out for that. I would suggest if your patient has a metabolic acidosis and has this sequelae of events happening, that you convert them back to pressure control, assist control ventilation. Another thing that we're experiencing is management of respiratory alkalosis. As I mentioned before, that alkalosis comes with hypocarbia, which can reduce cerebral blood flow and depending upon the length and severity, lead to neurodevelopment delays. What's really unclear is what is the drive of the hypocarbia. Now, this is not just tachypnea because of respiratory distress, because in that instance they would have hypercarbia and respiratory acidosis. This is the patient is perhaps tachypnic from another drive to breathe. This could be something like discomfort, pain, perhaps an immature respiratory center. And so you have to balance the hypocarbia, which we know can have significant neurodevelopment impacts, plus lung protection. When we have these types of patients, who do develop this hypocarbia, the desire is to decrease ventilation. And so sometimes what we wind up doing after a discussion is turning the target tidal volume down by some, but you have to be very careful that you're not turning it down too much, because at some point you get to just anatomic dead space ventilation, which your CO2, yes, will rise, but then the patient has no way of regulating it, so it will continue to rise. The other thing is, if you turn the tidal volume down without understanding why the hypocarbia is happening, the patient is just going to continue to breathe faster to be hypocarbic. It's really unclear why the brain or the chemo and pressure receptors are looking for this hypocarbia or allowing this hypocarbia, but we do have to balance that, plus also not turning the ventilator down so much that the patient is now under supported and we don't have good lung protection, because we run into those other problems of under supporting the patient. Another issue that we see is excessive effort, which kind of ties back to both of these, depending upon why the patient is breathing so fast and becoming hypocarbic. Patient can have excessive effort for that. They can also have excessive effort when they have a metabolic acidosis as they're trying to lower their CO2 to make their pH normal. This can lead to decreased support, as I detailed when we talked about metabolic acidosis. There are subjective measures to it. As we've relied on for decades and decades, you can look at things like nasal flaring, degree of retractions, tachypnea. Those, again, are subjective. Retractions from one person to the next can either look severe or not severe. There are objective measures that you can look at, and I will say this with caution because they're not so well defined in neonates, but I think it's important to look at them and consider them. The esophageal pressure, as we saw in that graphic from the metabolic acidosis slide, can be very helpful in quantifying effort in patients. However, esophageal catheters that have a balloon on them that can measure esophageal pressures are not as common and especially not readily available for patients who are low birth weight. They just are not that small. So it can be something that's used, but again, it's not so operational. The P0.1 is another measurement that is well defined in adults, but not so much in neonates, but again, something to look at, and I think I would suggest to trend these values. The P0.1 gives a brief occlusion during the patient effort and looks at the pressure generated in the first 100 milliseconds of every effort. That when that pressure is exceedingly negative, that means that the patient is breathing incredibly hard, meaning generating a lot of negative intrathoracic pressure to actually develop a breath. If the value is somewhere, around the 0 mark or even a little positive, that means that the ventilator is perhaps supporting the patient sufficiently. Those are values, though, in adults. We don't necessarily have validated values in neonates. So that's why I think the trend is really important. And you can see that, and again, the NeoEncode ventilator, you can actually program it on this side for repeated measures every 30 minutes. And this is what our practice is. So we can see the value over time. You can see this one went from 0.5 to negative 0.5 to 1.2. So if there were ventilator changes made here for this negative 0.5, you can either assume or think that maybe there was a positive improvement and we're supporting the patient better now at this 1.2. Do want to caution that this is not validated in neonates, but again, something to look at and to consider. So in conclusion, along with barotrauma, which has been something that we've talked significantly about in neonatology for decades, volutrauma and Adalecc trauma also play a large role in ventilator-induced lung injury. As neonates are growing and we want to preserve any lung that is developing, we do need to be careful what volume and pressure we're actually delivering to these infants. The technology to deliver small and targeted tidal volumes has certainly evolved. I remember when I was a new RT in the NICU, we often quantified sufficient tidal volume delivery by looking at chest rise. Again, so subjective, it looks sufficient, and that's kind of where we started from. But now we do have this technology to really look at what these small tidal volumes are, even down to 1 ml. The accuracy is certainly there. Data of, again, the last Cochrane review shows that, across many different studies that volume targeted ventilation when compared to pressure limited ventilation can reduce the rates of BPD, pneumothorax, IVH, PVL, hypocarbia, as well as duration of mechanical ventilation. I know that these all sound wonderful, and if you work in the NICU, you probably think about these more long-term impacts on patients and families, but any way that we can have patients and families go home without a ventilator because they don't have grade 3 BPD is certainly a win. Challenges can lie in practice changes, making sure that the equipment that you have available meets your needs. Practice change can be difficult. especially if you've been, using one mode of ventilation for a prolonged period of time. That change does require effort and significant education. Also, we have challenges in the expertise of management, as it is a mode that's on the newer side. It's not totally new, but it's certainly not used as widespread. But that's nothing that we can't overcome, especially when we recognize the impact that this can have long-term on our patients as well as our families. So with that, I would like to thank you. If you have any questions, you can feel free to reach out via the address listed on the slide. Thank you.